In the current video, we're going to cover techniques that are used to control or alter pain experiences. First, advances in pharmacological methods inform how direct introduction of specific chemicals and drugs into the system can reduce pain experience. Drugs as pain relievers have long history with humans. For instance, ancient cultures discovered the euphoric effects of opium poppy, which Sumerians referred to as the joy plant, and ancient Greek and Roman physicians used as a tool to induce sleep and give relief to the bowels. Today, the chemicals in opium are used to create morphine, which is a powerful, albeit addictive, pain reliever. Ancient Sumerians and Egyptians would also chew on willow bark as a way of reducing inflammation and relieving pains for specific aches, and Hippocrates, the father of medicine, later used the same willow bark in tea to ease the pain of childbirth in 400 BC. Fast forward 2,000 years, and scientists identify a specific chemical in willow bark, which we now purchase over the counter as aspirin. These drugs act by inhibiting the body's ability to sense pain, either by blocking that ability for nociceptors to send pain signals or by influencing the threshold that nociceptors activate. That is, either no signal gets through or the signal is never sent. Aspirin and ibuprofen fall into this latter category.
But the pain threshold isn't set in stone. Certain chemicals can tune nociceptors, lowering their threshold for pain. Now, when cells are damaged, they and other nearby cells start producing these tuning chemicals like crazy, lowering the nociceptor's threshold to the point where just touch can cause pain. And this is where over-the-counter painkillers come in. Aspirin and ibuprofen block production of one class of these tuning chemicals, called prostaglandins. Let's take a look at how they do that. When cells are damaged, they release a chemical called arachidonic acid. Now, two enzymes called COX-1 and COX-2 convert this arachidonic acid into prostaglandin H2, which is then converted into a bunch of other chemicals that do a bunch of things, including raise your body temperature, cause inflammation, and lower the pain threshold. Now, all enzymes have an active site. That's the place in the enzyme where the reaction happens. The active sites of COX-1 and COX-2 fit arachidonic acid very cozily. As you can see, there's no room to spare. Now, it's in this active site that aspirin and ibuprofen do their work. So they work differently. Aspirin acts like a spine from a porcupine. It enters the active site and then breaks off, leaving half of itself in there, totally blocking that channel and making it impossible for the arachidonic acid to fit. This permanently deactivates COX-1 and COX-2. Ibuprofen, on the other hand, enters the active site but doesn't break apart or change the enzyme. COX-1 and COX-2 are free to spit it out again, but for the time that ibuprofen is in there, the enzyme can't bind arachidonic acid and can't do its normal chemistry. But how do aspirin and ibuprofen know where the pain is? Well, they don't. Once the drugs are in your bloodstream, they're carried throughout your body, and they go to painful areas just the same as normal ones.
On the plus side, pharmacological painkillers are extremely effective at reducing pain. Unlike the inhibitory interneuron, which simply reduces pain signals, these drugs completely block it. However, they come with a significant downside in that if taken too frequently, they can develop addictions and tolerance as well as other side effects. For instance, aspirin can erode stomach lining if taken too often, leading to gastrointestinal issues. Moreover, the past few decades have seen a steady rise in opioid addictions and abuse, leading to what we now term the opioid crisis, which costs tens of thousands of lives each year. Apart from the physiological aspects of addiction, this overuse and addiction stems from psychological and social issues, such as poor coping with post-traumatic stress disorder, poor adherence to recommended dosages, and social conditions leading to recreational abuse. Thus, the pros and cons of pharmacological methods need to be weighed carefully. Another major pain intervention is surgery. If pain is just electrical signals that go from the nerves to the spinal projection neurons and then to the brain, then there are two options. Either we sever the link between the pain fibers to the spinal projection neurons, or we can sever the link from the spinal projection neurons to the brain. Surgery easily accomplishes this and is highly effective at short-term pain reduction. No signal can travel because there's no longer a bridge. However, surgery is very expensive and pain interventions are not covered by all insurance providers, as well as lost wages for post-operative recovery are not necessarily protected. There are also potential side effects, such as infection or losing not just pain sensation, but all sensation. And finally, the human body is actually evolved to re-knit neural connections. Thus, the severed bridge may eventually heal and regenerate, leading to similar or potentially worse pain experience, particularly if surgery is not coupled with other physical therapies to alleviate the true source of pain. Therefore, surgery often has greater risk than long-term benefit. But due to psychological motivation to reduce pain, people may often outweigh the benefits in the moment, choosing the riskier option. Thus, patients benefit from greater doctor-patient communication prior to surgery, as well as efforts to fully investigate alternative methods of long-term pain relief. If surgery is the chosen option, patients also benefit from communication that enhances understanding of the procedure and recuperation period. These two methods of controlling pain are a focus of biomedical practices. But in the next video, we'll take a look at other methods that follow a more biopsychosocial approach to understanding pain relief.